Mm. Hello and welcome to today's webinar for mental health professionals, an introduction to prolonged exposure therapy for PTSD, featuring David Yusko. My name is Astrid Masfar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you'd prefer to join over the telephone, just select telephone in the audio panel and the dial-in information will be displayed. You will have the opportunity to submit text questions at any time during the presentation by typing your questions into the chat box of the control panel. You may send in your questions at any time and we will collect these and address them during the Q&A sessions throughout the presentation. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation. You will receive a follow-up email including the webinar evaluation, webinar recording, and post-test assessment for those seeking CE credit. You will also have the opportunity to complete the post-test assessment after the presentation. The questions will appear on your screen and you will be given 5 minutes to complete the assessment. Once you complete the assessment, please click Submit. I would now like to introduce Dr. David Yusko. Dr. David Yusko received his PsyD in clinical psychology from the Graduate School of Applied and Professional Psychology at Rutgers, the State University of New Jersey. Dr. Yusko is one of the handful of experts on the concurrent treatment of PTSD and substance use disorders and has consistently worked on small to large dissemination projects that brought prolonged exposure to every kind of mental health setting around the world. Dr. Yusko is the co-founder of the Center for Anxiety and Behavior Therapy, and he continues to provide evidence treatment in his clinical practice, regularly trains mental health professionals in effective treatments for trauma and anxiety, and presents on issues associated with PTSD at local and national professional organizations. I'm now going to take a moment to pass the screen to our expert. There will be a brief pause while I do so. All right, Dr. Yusko, you may begin your presentation.
Thank you, Astrid. Good morning, good afternoon, everyone. I'm happy to spend the next hour together with all of you. I'm going to put my slideshow here up for you guys to see. As Astrid was describing earlier, I'm going to take breaks throughout the presentation. You'll see slides that'll come up where we have opportunities to try to answer questions as we go along. So as we work through our agenda, generally speaking, at about after each agenda topic, we'll have an opportunity for questions. And so you can submit your questions at any point that you have them. And then as we get to these question and answer points, we will read your question so everybody can hear it and then go through it. And so we'll try to spend 2 or 3 minutes at each one of those. So the agenda for us for today is going to be a brief review. I want to make sure as we talk about prolonged exposure for PTSD that we have an agreement on what that topic is, PTSD. And then I want to get into a little bit about how prolonged exposure was developed, the theory behind it. I believe that the theory behind it will help us understand why we do the interventions that prolonged exposure therapy asks its clients to do. I want you to be able to know that because in the therapy itself, we also want to be able to explain this to the clients we're working with. So we'll talk a little bit about that theory. Then I want to give you an idea of what treatment would actually look like. Therefore, like a quote unquote, what a standard course of treatment would be. And I'd like to go through what each of those sessions would require. And then kind of at the end, talk a little bit about some data, not a lot, but a little bit of data that shows you how this can work with certain populations and just how safe doing trauma work with exposure can be. There's always questions I come across with folks about doing exposure therapy in a trauma population and some concern over whether that's really effective / safe and good for folks. So we'll talk a little bit about that at the end. So thanks everybody for being here and looking forward to spending the next 50 minutes or so with all of you guys. So getting into what PTSD is very quickly. It's one of the few diagnoses with mental health where an event actually has to have occurred in order for you to have a diagnosis. And so whenever you're screening someone, the first thing to screen for is whether or not a person has had what's called a criteria A traumatic event. Examples of that are posted here on this slide. That experience can be directly happening to the person. It can be witnessed by the person. It's happening right in front of them, but it happened to someone else. And the last way in which it can happen is someone has been told about it. In that example, when someone learns that something happened to someone else, that person that it happened to has to be very close to them. So by definition, it has to be a person who has a central role in your life. It can't be, cousin Joe that you haven't seen or spoken to in 5 years. So a criteria A event has to either be directly experienced, witnessed in front of you, or you learn about it from someone, and that if that's something that has happened to someone very close to you. And these are really gauged towards being life-threatening events. There are problems with this definition. It doesn't capture everything, but based on what the committee of DSM-5 decided, this is what we've got to work with. If you cross that threshold, you may then be assessed for the remaining symptoms of PTSD. And very quickly, those symptoms have these categories. You have to have intrusive symptoms, avoidance symptoms, changes in cognitions and mood, and then alterations in arousal and reactivity. PTSD has to be at least 1 month post the trauma. Anything less than 1 month is more accurately acute stress disorder. And then we have those other same types of ideas where it can't be the cause of something else. It can't be because of a substance use or a medical issue. That PTSD symptoms are in fact derived from the experience of the trauma and are a result of that experience. So PTSD in a nutshell, that's kind of the idea of what we're talking about with these folks. And whenever I like to talk about evidence-based treatment, I just want to spend one slide talking about evidence-based assessment. I believe that our treatments can only be as good as our assessments are. The nice thing about PTSD is that as clinicians, we have free access to really good, reliable self-report measures as well as interview measures. These measures are listed here on this slide. For example, the CAPS and the PCL, those are free measurement tools that you can get from the National Center for PTSD as an example. The PSSI-5 and the PSSR-5, those are tools that were developed by Dr. Edna Foa, and that she uses a lot in all of her research studies as well as in her clinical outpatient practice. I really would encourage everybody to, at a minimum, to access and use these self-report measures. They have great reliability and high correlation between positive scores on that and actual diagnoses. So a good assessment can help us determine the appropriateness of using PE with any given person. So evidence-based measures to use at least at the beginning, and I'm going to encourage folks to use self-report measures throughout treatment. As an example, this slide is looking at community mental health agencies in Philadelphia, where we were only using the self-report measure, the PSS SR5, that self-report tool on the prior slide. And each of these agencies on the left-hand side of your screen there adopted that measure and started giving it to every client that was coming into their practice. And as you look at these agencies, NHS, JJPI, those are mental health outpatient. And then you have also substance abuse agencies, the Consortium, Chances, Gaudenzia, my sister's place in Caton Village. Those are residential substance abuse facilities. The reason I'm encouraging you to look at this slide is there's a lot of people that got screened over a handful of years. You can see over 10,000 people were screened in these agencies. By screened, meaning they got that self-report measure and they filled it out. And so what you're seeing is, and this fits what national comorbidity data also tells us, at a minimum, 50%, 55% or so of folks are talking about having experienced the trauma at some point in their lifetime. I'm going to show you a slide in a second that backs this idea up. And what we're saying with probable PTSD, what we mean by that is 40%, 4,000 of that 10,000 folks who responded identified a score on that self-report that was above the identified cutoff for having probable PTSD. Now, my practice as a kind of boutique clinic is going to be different from a community mental health clinic. But that being said, if you're engaged in a community mental health clinic population, the reason I'm encouraging that screening is because at 40% of those folks are presenting with PTSD diagnoses, and very rarely are people picking up on those on that diagnosis. And we can talk a little bit more about that. It also varies by site. So if you look at, as example, JJPI, which is a mental health clinic, 43% versus Consortium, which is a substance abuse clinic, upwards of 57%. So we also know that by population, the prevalence rates of PTSD do vary. Substance abuse clinics will generally have higher rates of PTSD than mental health clinics. Nonetheless, I just love encouraging people to take that screener, the PCL or the PSR. They're easy to administer, and they can give you a rich amount of data in a short period of time. To follow that up, this is data from the National Comorbidity Study. And so this is looking at folks across the country, not just people presenting to community mental health clinics. And what you see on average, right, in community mental health clinics, somewhere around 55% of the population is saying they experienced a trauma. That's what the community of the US population is saying also. 61% of men, 51% of women are saying they've at least experienced the trauma, with about half saying they experienced one criteria A trauma event, with another half or so saying two or more. So the idea that people experience one trauma does exist, even though those generally aren't the folks we see in therapy. They're out there. The folks we generally see more of are the people on the righter side of this slide, two or more traumas, and they make up about half of the people who have experienced the trauma. In terms of diagnosing PTSD, this slide is meant to show that the type of trauma, as you go across the bottom, does matter in its ability to translate into a PTSD diagnosis. So the trauma type in red shows you what percentage of the population is endorsing having had that kind of trauma. So the good news here is that the more prevalent traumas, natural disasters, car accidents, things like that, are the least likely types of trauma to also lead to a PTSD diagnosis. What you see happening as the type of trauma becomes more interpersonal, more human being to human being, and more violent, the rate of PTSD goes up significantly. And I really just want to highlight this idea of sexual assault, whether that's for men or women. The prevalence of sexual assault might appear to be low, but the rate at which that it causes PTSD is very high. Over 1 out of 2 folks who have experienced a sexual assault do go on to develop PTSD symptoms. So not all traumas are created equal in its likelihood to translate into PTSD symptoms. Just another thing to keep in mind as you're gathering trauma histories from your clients, types of traumas, and the ones that may stand out to them more do matter. Car accidents potentially being less traumatic and leading to PTSD, combat, childhood molestation, adult experiences of sexual assault, much more likely to translate into PTSD symptoms. And I want to show the progression of how PTSD symptoms present themselves, what seems to be a normal response to a trauma, and how PTSD begins to develop over time. The reason I want to show you this slide is because it's going to dovetail very nicely into the theory behind prolonged exposure. So what you're seeing here in red, those are sexual assault survivors, and in yellow, those are non-sexual assault survivors, physical assault, fights, stabbings, things like this. And what I want to show you, importantly, on the left-hand side is in 1 week after a trauma, it is extraordinarily common for people to have many symptoms of PTSD, right? So what we're seeing is even though 1 week after a trauma you can't be diagnosed with PTSD, they're still having those acute stress disorder symptoms, and they're having a lot of them. 80+% of sexual assault survivors will meet criteria for PTSD or acute stress disorder in that first week after a trauma. As you look, though, across the slide, as you go from left to right, as time passes, what you're also seeing is a lessening, a natural recovery of symptoms. But what you also see is that it starts to flatten out. Natural recovery will start to plateau as you get towards 3 months, but absolutely as you get towards 6 and 12 months. The idea here being that within the first 3 months after a trauma, it is very common for people to have a lot of symptoms. In fact, I wouldn't even say it's a pathology. I would say it's a normal response to a traumatic event to have many symptoms in the first 3 months after a trauma. And it's very common for those people without any help at all to naturally recover from those symptoms. What you begin to see, though, is that at some point, these folks, the rate of natural recovery goes down. And as you get out towards a year after a trauma, if you encounter someone who's still having PTSD symptoms, the likelihood that those symptoms will go away without a specific trauma intervention goes way down. And that also would include medication. So if someone has been taking medication and you're getting closer to 6 or 12 months after a trauma, if they have not recovered, that's the time to really begin to seriously consider a trauma-specific intervention. Any questions so far? Just based on, we understand what PTSD is, the prevalence rates, assessment tools, trajectory of symptoms. Any questions that anyone have so far?
As a reminder, everyone, you can submit questions through the chat box on your attendee control panel. So we can give everyone a minute to type any questions if they have any.
Seem good so far?
Yep, great so far. Audio's great and the webcam's great.
Okay. And no questions yet.
We have one question.
Okay.
What does these rates look like for survivors of child abuse?
So survivors of child abuse, if I just go back to this one slide here, survivors of child abuse, these are adults. This molestation category are assessing adults who are identifying a childhood sexual assault experience as their index trauma for their PTSD symptoms. So you can at least see the prevalence of rate of that occurrence in red, as well as around 20% of adults who experience childhood sexual assault having PTSD at some point in their lifetime. As it relates to this is where this slide doesn't fit those people as well. This is really looking at adults in their immediate response to a trauma. So an adult with a childhood sexual assault history may be more like the people on the very end of this scale, but even more past the 12-month mark. These are folks whose traumas are very old, yet struggle of their PTSD symptoms remains. These would be people that I would also be saying the time for an evidence-based intervention or a trauma-specific intervention is really important to give them access to.
All right, we have another question. At what point would you diagnose acute stress disorder if you see a traumatic response being a natural response to trauma?
So if someone, for me, the value of acute stress disorder is if someone's coming into treatment at that time, that you have a diagnosis that you can give, and that primarily allows for potentially like insurance reimbursement. I don't know that interventions for acute stress disorder are very well researched. So we have things like psychological first aid, um, the briefing interventions after traumas that people do mostly in groups. You've had Barbara Rothbaum do a intervention right after sexual assault. The downside is that we don't really have good research on how you can prevent the development of PTSD. So the terms of what we do with these acute stress disorder folks, I think is more about not necessarily the time to do an evidence-based intervention as much as to give them room and support to talk and give psychoeducation, meaning it's very natural for them to have these experiences. And over time, it's very natural that these symptoms will go away with some support and help, but very likely on their own. If you're with someone and you're getting past 3 months and those symptoms aren't going away, that's when I would begin to have a new conversation with them about more specific treatment ideas. Good question.
Okay. Yes, we have time for one more question during this Q&A session. Many of the symptoms of PTSD and grief bereavement are similar. How can you determine the difference if a patient has lost a close friend or family member?
So I'm sorry I didn't put this on there. On this slide here, there is Kathy Shear out of Columbia in New York City has a really good complicated grief measure. It's a self-report measure as well as a clinician interview that she uses. And you are 100% right in your question that you will see a lot of overlap between these a complicated grief presentation as an example versus a PTSD diagnosis. And what's interesting is that Kathy Shear has also developed a treatment model that really incorporates a lot of what prolonged exposure does in its therapy as well. So even though there may be a differential in the diagnosis, the approach towards helping them is going to actually look very much the same. But what I might use as I would decide which kind of measure I'm going to use to assess those symptoms. Does this look better in a complicated grief assessment, or does this really seem better with the PTSD assessment? And then I would follow my treatment protocol accordingly. Even complicated grief protocol, though, is going to look very similar. And if you have questions when I go through what PE looks like, you can ask about how I would address grief in that paradigm. We're good so far?
Yes, that was the last question.
All right. So emotional processing theory, there's a great article, came out in 1986, where Edna Foa and their colleague kind of like described what emotional processing theory is. The idea is that it's trying to explain why the early symptoms occur, how natural recovery occurs, but also how PTSD develops, it is maintained, and what treatment should do to address it. So the idea behind emotional processing theory is that embedded within, our bodies, within our brains, is this concept of an emotional structure or a fear structure. And what that structure is essentially it's a program. It's a program that gives us information and kind of tells us what to do when certain things are present. And certainly when we're in the midst of a traumatic event, this is when that fear, fight, flight, freeze scenario presents itself. And what this structure does is it immediately gives us information. It gives us information about the stimuli that's present, about the responses that occur during the presence of that stimulus, and then an attempt to make meaning of the stimulus and the responses. What do I mean by that? So many of us have either been close to being in a car accident or have been in a car accident. And I'm sorry to use that example if that hits a little close to home for folks. But what I want folks to try to do is to use a car accident as the stimulus. That stimulus immediately provides a structure for how to respond. And if anyone has almost been in an accident, you immediately know what it feels like within your body and what your body does. Those are the responses, right? Your heart rate immediately starts to go up. Your hands immediately start to grip the steering wheel faster. Your feet slamming down on the brakes. You're turning the steering wheel. You're bracing your body for impact, right? The stimuli and the internal and external responses all become a part of that emotional structure. And then to some degree, we're making sense of that. For instance, a healthy response might be, wow, that was really close. Lucky thing I was paying attention and I was able to go around this and get away with it because, oh, that could have been a lot worse. Versus a less healthy response where, what's wrong with me? Why couldn't I have done that sooner? I must be a lousy driver and the world is much more dangerous than I thought it was, right? The body is trying to make meaning out of the stimuli and the responses that were present. So a traumatic memory is a type of emotional structure. And if you can imagine the stimuli of a car accident, all of the stimuli that's present during and after that trauma become encoded into the structure. Smells, sight, what you see, what your body feels, what emotions you have, any thoughts that you had that you didn't say out loud, any other things that people said. All of your senses are taking in information, are taking in stimuli. And then there are those responses, the physiological and the behavioral responses that occur. That's where fear, guilt, shame, anger, freezing, how you acted, and then how do you make sense? How do you make meaning? Was I helpful in that moment? Was I hurtful? Could I have done more? Those types of associations can be realistic or unrealistic. Um, Sometimes a phobia is a good way of relating to this idea. For me, it's always spiders. And the stimulus is very clear. If I see anything crawling on the floor, I immediately have a physiological and a behavioral response. And then I make meaning out of that. I oftentimes will chide myself by saying, "What is wrong with you? This is just a little spider. There is nothing that big of a deal." So it's a minor example to try to explain a much more complicated and bigger example here of what a trauma is. But the idea being the stimulus and the response. And the response is super important because how we make meaning between the stimulus and the response matters incredibly. So coming back to this idea right after a trauma, what did we say? It is very likely for a lot of symptoms to be present and very likely that we're going to have excessive responses, a lot of memories of the trauma, a lot of nightmares, a lot of agitation, a lot of mood instability, a lot of avoidance of wanting to get back to doing things again. And you can even begin to cause someone to believe, what is wrong with me? Why can't I get over this? This happened already. And people begin to just feel awful about themselves, and they begin to think awful about the world around them as well. Very common to happen early on after a trauma. Again, if anyone has been in a car accident, you can remember right after that car accident, everything around you stimulates the memory of that car accident and how dangerous getting in a car could be. In fact, if you think about driving in general, it's amazing that we all do it. We're in these big vehicles going fast, and somehow we all stay in our lanes, and we don't get into accidents as often as you would think that we do. However, right after an accident, you lose the ability to suspend disbelief, and you begin to think, "Oh my goodness, driving is actually very dangerous." And you begin to think, maybe I'm not as good of a driver as I thought I was, or maybe I can't trust other people to be as good on the road or to be as trustworthy as I thought. And so right after that, you're less inclined to get back into your car again. You're a little nervous about doing it. You start to avoid it. Very common, very normal. At some point, though, most of us, we get back in that car and we don't get in the car free from some type of distress. Meaning, even though we're still afraid of what might happen, we're still scared that driving may not be as safe as we thought. Most of us get back in and we try it again. And the good news is, when we do that, most of us get in that car and we arrive to where we're going. And we get that moment of saying, "Oh, thank God I made it." But doing it once isn't enough. You then get back in your car and you have to get home. And you tell yourself, "Well, I got lucky coming here. Maybe going home won't be as good." But you get back in your car, you're nervous again, you're still afraid, but despite that, you get in, you drive, and what happens? More often than not, you get home or you get to where you're going again safely. What that does is it begins to give corrective information. And if you keep driving, what a person begins to learn is that over time, they start to remember, "Oh, I've actually been driving for a while and I don't get into accidents very often. I think I might be an okay driver." And believe it or not, other people seem trustworthy on the road. That corrective information starts to fill the space that was being taken up by fear and worry about how dangerous the world and other people can be. And that happens in the context of emotion. You don't get back in the car when you're feeling fine. You get back in the car when there still exists apprehension. And it's in the presence of the apprehension that the corrective information comes. And that's really important. That happens in natural recovery, but that's also what can either limit natural recovery, but also promote change with PTSD. What our argument in emotional processing theory is about what develops and maintains PTSD is that people don't, for instance, get back into their car. That a more chronic and more rigid approach of avoidant behavior starts to take over. And as avoidance starts to dominate a person's life, PTSD starts to get more and more prevalent in their life. And so driving becomes dangerous. Not only can I not drive, but I don't want to ride in the car with other people. And if cars are dangerous, maybe buses are and trains are. And what you begin to see is a generalization or a spreading of that fear, of that concern, of that distress. And so when you limit that experience of apprehension, you also limit your ability to get corrective information. And when you limit that corrective information, you start to solidify trauma-related thoughts and beliefs. I might not be as competent as I thought I was. Other people aren't trustworthy, and the world is more dangerous than I thought. Avoidance will crystallize those thoughts, and then those thoughts will dictate more avoidant behavior, and the two just feed one another. If this hypothesis is true, this is why prolonged exposure therapy relies on these two core ideas. The two areas where people avoid the most are internal reminders and external reminders. Internal reminders are generally the memory and the emotional and physiological experiences of that memory. Therefore, prolonged exposure relies heavily on what we call imaginal exposure, which is where we revisit traumatic memories in an attempt to help people process them, digest them, and help make more realistic perspectives on what happened, challenging those trauma-related thoughts and beliefs. Second, in vivo exposure. What do we mean by that? The things external to us that are reminders. If you're using the car accident again, looking at cars, sitting in a car, driving in a car, etc. The smells of gasoline, things like this, things external to us that are reminders that we avoid. We want to begin to do normal, safe, quote unquote. Nothing is free from risk, but there are things that we do that are generally considered safe. And those are the things we want people to begin doing again. If avoidance is what's driving the development and the maintenance of PTSD, we want to kind of combat avoidance by approaching. And exposure is the way that we approach the things that we're scared of, nervous about, ashamed of, feel guilty around, etc. So imaginal and in vivo exposure will be our two main areas of intervention. I don't want to get too much into the data, but I do want to show you that prolonged exposure is unique in it's so rich in its research history. Very few treatments have this many number of randomized clinical control trials. The reason I'm showing that to you is because prolonged exposure is not an experimental treatment. This is a treatment that we know from an exhaustive amount of literature tells us that it works. Given that exhaustive literature, when the Institute of Medicine was putting out a report on the gold standard treatments for PTSD, they concluded that above all treatments, medication included, that exposure therapies had enough data to conclude that they were the gold standard of treatment. That's not to say that there aren't other treatments that are very good and very effective. They were only commenting that the breadth of research makes it not even a question anymore when it comes to PTSD. So part of the advantage, prolonged exposure, cognitive processing therapy, EMDR, etc., All very good treatments for PTSD. Why would prolonged exposure have an advantage? That number of studies helps. Because of that number of studies, we have a wide range of types of traumas as well as types of populations. And they haven't only been done in the US, but this is research that's been done literally around the globe, from Asia to the Middle East to South America to Europe, all over. Researchers have done studies testing the efficacy of prolonged exposure within their populations and within their trauma types. So not many other treatments can have that breadth of knowledge behind them. If you're deciding whether to use PE or not, the first thing I would like you to know is that PE is a treatment for PTSD, not because someone has a trauma history. So a diagnosis and having that diagnosis is very important. Without having PTSD or at least subthreshold PTSD symptoms, those are adequate patients for this type of a treatment. We also have to have a specific traumatic event. Most people have had at least one, but they may have many. In PE, what we're asking people to do is to identify one specific traumatic memory that they feel is the worst of all of them. And we don't want to do it to a general idea of, take for instance, if a person was a domestic violence situation and they were under repeated instances of violence, we don't want to do a memory to this is how it generally went. We want a specific instance of violence and we want to review that memory. Therefore, if a person does not have a memory of the trauma, we cannot do PE. They don't need a full memory. They may only have flashes of a memory. That's okay. That's what this idea down here about fragmented memories. That's okay, but we have to have a memory. So this is a treatment for PTSD. We want a specific memory, and we just have to have a memory. And there aren't many people that I would say we can't do this with. And these are I think, these are fairly common sense ideas, right? If someone is imminently suicidal or homicidal, we're not going to do any type of treatment with them. We are going to intervene. So, if someone's suicidal, that's not a time to be doing PE. If someone is engaging in excessive, serious, ongoing amounts of either self-injurious behavior or even substance abuse behavior that's not under any management or control, that probably isn't a good person to start doing PE with. We have one study that was done with psychotic patients. I'll show you that in a little bit. And it was positive, but it's only one. So I'm a little cautious in terms of psychotic patients and the use of PE. The one study says, though, that it's a decent idea. And then the last comment here is really getting at there can be other disorders that warrant treatment before PTSD. If you're so depressed that you can't get out of bed and get to therapy, depression requires treatment first before PTSD. If your panic is so scary that you're more afraid of panic than you are your memories, we have to help a person with panic before we can start doing PTSD treatment. So that's getting at the primacy of a disorder. That being said, I also want to highlight that trauma and PTSD often does not occur as a sole presentation. These folks are generally complicated and come in with multiple problems. And just because they have multiple problems, that doesn't mean PE won't be okay. The question is whether or not they're in a place where PTSD is the primary diagnosis and that treatment can be focused on that issue at this time. So being suicidal isn't as bad of a problem as I'm imminently suicidal. That's what will trump using PE or not in an example like that. Questions so far? All right, I'm going to keep going. We're having a little bit of, I want to just make sure we can keep talking. I want to tell you a little bit about the treatment. We have more time for questions in a second. Typical course of treatment is 8 to 15 sessions. I want to put it out there. Almost all the research is based on 90-minute sessions. I know that that's not conducive to real world practice. Therefore, there's one study that was done, but even this looked at a full 60 minutes of a session. The fact that that one study showed promising results means I'm encouraging people, if you can only do it in 60 minutes, fine, let's do it. If you can get 90 minutes, that's ideal. This example that I'm going to show you is based on a 10-session treatment model, but this can be modified as needed for any given person. What I'm assuming before session 1 starts is an assessment has occurred and there's an agreement between you and the person that this treatment is what's warranted at this time. If that's been decided, then we're going into this treatment. I should have put the slide up here. I'm sorry I didn't with a picture. The Treatment That Works series by Oxford University Press has a treatment manual for prolonged exposure. It also has a client workbook. If you go on Amazon, you can buy that manual and that workbook together. It's under $50. That manual will go through every one of these sessions. Session 1, again, is very much about what we just got done talking about. It wants to give a rationale as to how PTSD develops. So it talks about avoidance and it talks about how exposure is going to help break the cycle of avoidance and help a person get better. We also identify the index trauma during session 1 when we're doing the standardized trauma interview. And we end that session with basically a diaphragmatic breathing exercise. I want people to have skills in place to help manage distress. And so early on, we're introducing breathing as a strategy for managing distress. And then we have homework. We audio record all of our sessions in this treatment because we ask clients to listen to them in between appointments. We also have handouts. And so they're going to read the rationale, they're going to listen to it again, and they're going to practice their breathing. In the research protocol, session 2 is so big that in practice, I find it's easier to break it into 2 sessions. So I'm calling it session 2A and 2B. You could do it all in one session, but I'm suggesting break it into 2. So the idea here is if you were going through session 2, we want to check homework. We have more psychoeducation about the common reactions to trauma. If you go on YouTube and you look for Dateline and prolonged exposure, there's a nice video. It's a little dated. It's from the 90s. We show that video to clients so that they can see a person's experience doing PE, and we can talk to them about what that experience was like. It's about 10 minutes. We watch it with them. We discuss it with them. Usually, I'm sorry that this slide is messed up here. Usually that's where session 2A ends. And the homework for them is to listen to the session, review the common reactions to trauma, and do their breathing. 2B is really about the construction of the in vivo hierarchy. And I'm sorry that this slide is incorrect prior. There's a rationale for in vivo. We want to develop the SUDs, the subjective units of distress. That's how you differentiate one item from another on a hierarchy. You put that hierarchy together, and this is your first exposure homework exercise. They will go home and do their first exposure as homework. Session 3, we're going to start imaginal exposure. This could be session 4 if we've done this in 2 ways. But session 4, imaginal exposure, that's where we revisit the trauma memory for 30 to 45 minutes. If you're in a 60-minute session, 20 minutes. And then we talk about it, and then we assign homework. This week, in vivo homework, They are going to listen to the imaginal exposure every day, and they're going to continue to do their breathing. From this point on, the treatment is the same. They will come in, you will check homework, you will do imaginal exposure, you will process that exposure, you will talk with them about what it's like, and then you will assign homework. Continue to do the breathing, continue to do in vivo exercises, continue to listen to the memory every day. Typically, after 3 sessions of that, we take the whole memory and we narrow it down to what we call hotspots. And so in this instance, what a hotspot is, it is the hardest scene of a memory. So we've taken the whole memory and we've reduced it to the hardest scene. And we only go over that scene during our imaginal exposure. Nothing else is different though. Imaginal exposure to the hotspot, processing of the imaginal exposure, and we assign homework. We will work on the hotspot until we are done with treatment. And session 10 is our last session. We go back, we put the whole memory back together again, we revisit that memory once, and then we review what was the difference between revisiting that memory today versus the first time we revisited that memory. We take out their in vivo hierarchy and we ask them, if you were to go do each of these things right now, what would your SUDS be? We write that down and we show them the difference between when they scored that in session 2 versus today. The point being, what did they learn from treatment? What did they learn from doing imaginal exposure? What did they learn from doing in vivo exposure? What we're trying to highlight at the end of therapy is that avoidance maintains these symptoms and that by confronting things, you got better. You did not get better by coincidence. You did something to help those symptoms go down. The homework is generally to continue to apply the things you've learned, because there may be things that you still have to work on that didn't come up in treatment. A holiday, a birthday, an anniversary, an opportunity to go see fireworks because it's on your in vivo hierarchy, but you didn't have a chance to. So the homework is to continue to work on the things that were there based on the principles of exposure that they learned. So keep doing the things that they saw worked. The only reason I want to show you these slides is because I want to show you that we've done research with borderlines. We've done research with alcohol dependence in PTSD. We've done research with psychotic patients. We've done research with just regular PTSD folks. The point being, we've done research with all types of comorbid problems, and we've seen their PTSD symptoms get better in all of those groups, even though they come in complicated, even though they come in with other diagnoses. When you treat their PTSD gets better and stays better. The point behind this slide is to show you that when you follow up 5 to 10 years after treatment, these are treatment completers, the relapse rates to PTSD are extraordinarily low. We're almost out of time, so I just want to show you a couple of ideas about safety, because the idea of doing exposure scares people. And what I want to highlight is that some people do get a little worse in treatment when they stop avoiding and they start confronting, as you see in the yellow line. They do get more severe symptoms. But if they stay in treatment, they will end treatment at a point that is indistinguishable from someone who did not have an exacerbation. Meaning, even if you're one of these 10 to 20% of people who will have an increase of symptoms, you will not be different in your outcome if you stick it out. And do people get worse? Very few people get worse. The thing I want to highlight is the waitlist condition on the right side of your screen. The worst thing we can do with PTSD clients is nothing, is wait. But when we actively engage them in treatment, what you're seeing, very low percentages of people getting worse. When do they get worse? When you don't treat their PTSD, put them on a wait list or keep them in supportive counseling. And just the last thing I want to show you is that treating trauma is difficult, whether it's with exposure, whether with EMDR, whether with CPT. Dropout rates are higher than I'd like them to be, but it doesn't seem to matter what treatment you use, people drop out. And it's not just because of the exposure component, it's mainly because people want to avoid traumatic memories at all treatments. And so whenever you start to engage someone with their trauma, they're going to drop out of treatment a certain amount. And this is an area where we can certainly do better. You'll have these slides. I just wanted to show you that there is more training that you can get in PE. The Center for Anxiety at Penn runs these workshops. I run them. There's a 4-day workshop. It is great, and it can really teach you more about PE and how to implement it. It's a really good treatment for folks and something I'd love to spend more time teaching you guys about. But unfortunately, our hour is up. Thank you, everyone. I really appreciate your time. You have my email here. Feel free, please email me questions, thoughts, problems, anything that we didn't get to during the webinar. I'm more than happy to talk to you on the phone or answer questions via email. Thank you, everyone.
All right. Thank you so much, Dr. Yusko. And I also just wanted to apologize greatly that our Wi-Fi connection briefly went down here at the ADAA office. So I'm so sorry if that I missed the Q&A session during the presentation. But I did receive a few questions if you have some time to answer any.
I do, yeah.
Great. All right. So one question was, where would you categorize trauma as a result of persistent bullying in childhood and adolescence?
So to me, bullying as a kid fits the criteria A event of a trauma. And so what I would try to do in treatment is to pull up a memory of being bullied and to focus my memory on that. And then I'm going to build an in vivo hierarchy around the idea of bullying, whether that's looking at movies that involve bullying, looking at comedians that talk about bullying, going online and looking at images of bullies or even bullies from your past. So treatment is going to use bullying as the criteria event. We're going to isolate a specific memory of bullying to work on, and we're going to do in vivos that activate the bullying emotions. So I think it would fit just as it would any other memory type or trauma type. I have several people in my practice right now with bullying as their traumatic memory.
Okay, we have another question. Can the same PE intervention be used for repeated trauma, such as in the case of repeated sexual abuse?
Yes, absolutely. So the key here is to pick a memory out of all of the ones. And what I ask people to do is see if you can pick the memory that they feel is the worst memory. It's a somewhat of an arbitrary decision that they're making, but what we're talking about is when we do exposure, we get generalization to events that are lower on the hierarchy. It only goes down, it doesn't go up. So by picking the worst memory and by working on that memory, what you will get is generalization that goes down, and it will help heal the other memories also. So most of the time, you will only use one memory in treatment, but there are some times when you process one memory and then you still have to process a second memory. Fine, so be it. Generally speaking, though, you don't need to do 5, 6, 7, 8 memories. If you are able to pick the hardest memory, the worst memory, the memory that haunts them the most, you should be very effective with those chronic survivors as well. And many of the people in our research studies were chronic survivors of chronic traumas.
Thank you, Dr. Yusko. I believe that was the last question. And thank you so much for your great webinar presentation, and thank you all for attending today's training. You will receive a follow-up email shortly that includes the link to the webinar evaluation, webinar recording, and post-test assessment for those seeking CE credits. Please, if you'd like to take the post-test assessment after the webinar, please stay on the webinar platform after these few announcements.
Thank you, everybody.
Our next ADA Live webinar, Genetics of Depression and Anxiety, What Do Clinicians Need to Know, featuring Dr. Jordan Smoller, will be held on Thursday, December 6th at 12 p.m. If you're not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. Please visit ada.org to learn more about membership. We would also like to invite you to save the date for ADA's annual conference on March 28th to March 31st in Chicago next year. On behalf of ADAA and our presenter, we thank you so much for joining us today.